Hi, I'm Kathy Miller, Professor of Medicine at the Indiana University Melvin and Brent Simon Comprehensive Cancer Center, coming to you from the 2025 ASCO Annual Meeting in Chicago. It has been a great year for breast cancer with new data that should really improve the outcome for our patients. So let's think first about those patients with ER-positive metastatic disease. There is a wealth of options here, and I think it's going to take us several years to really figure out how to best use these agents. So first, let's think about our patients with hormone-sensitive metastatic disease. There are a wealth of new agents with clear activity available, and I think it will take us several more years to really understand how to best use these agents, how to maximize the benefits for our patients. So we had updates today from the Inavolisib trial. This is a trial you'll recall in very high-risk patients, those with really hormone-refractory disease, progressing rapidly either on adjuvant hormone therapy with an aromatase inhibitor or within 6 months of stopping therapy. Those patients were treated with a triplet drug regimen with hormone therapy, with palbociclib and inavolisib, compared to the doublet therapy. Now, we saw results of progression-free survival about a year ago, and now with updated results, there's an improvement in overall survival. Now, there are toxicity concerns here. We do need to manage hyperglycemia, manage the GI toxicities, the fatigue, and the diarrhea, but it's hard to ignore an improvement in overall survival. Now, the caveat to this trial is that it did not include a crossover, and only about a quarter of those patients had second-line hormone therapy. Now, there are a lot of decisions that go into whether patients get additional hormone therapy, they move on to chemotherapy, but this, for those very high-risk patients who are progressing rapidly on adjuvant therapy, is definitely an option worth considering. We also saw results from the first phase 3 trial with a PROTAC inhibitor. Now, these are drugs designed to result in degradation of the estrogen receptor, but mechanistically they do this in a very different way than the selective estrogen receptor downregulators. So they complex the estrogen receptor to a ubiquitinase, and that targets it to the proteasome for degradation. And at least biochemically, it results in more robust degradation of the estrogen receptor than the other available agents. We saw the results from the first phase 3 trial comparing monotherapy PROTAC inhibition to monotherapy fulvestrant in the second-line setting. Significant improvements in progression-free survival. Though realizing these are monotherapy studies, that's not how we typically treat patients in the second-line setting. So we'll need to consider combinations, think about the safety of combinations to really move this into practice. Now, finally, we have the results at the plenary session, the SERENA-6 trial. Now, this is a trial published simultaneously in the New England Journal of Medicine, and a trial that I think needs some very careful thought. So this is a trial with camizestrant, enrolling patients who were receiving first-line therapy with an aromatase inhibitor and any of the 3 available cyclin-dependent kinase inhibitors. Patients were eligible to begin screening for this trial if they had been on their hormone therapy and CDKI for at least 6 months, so really eliminating those with clearly hormone-insensitive disease. When they enrolled in the trial, they began screening with a ctDNA assay every 2 to 3 months, looking for emergence of the ESR1 mutation. We've talked about ESR1 before. This is a mutation that emerges under the therapeutic pressure of anti-estrogen therapy and certainly leads to relative resistance to the aromatase inhibitors, but preserved sensitivity to the estrogen receptor downregulators such as oral camizestrant. If an ESR1 mutation was detected, those patients then had staging scans, and if they did not have radiographic evidence of disease progression, so in prostate speak, biochemical evidence of resistance only, they were randomized to continuing their current therapy or switching the hormone therapy to camizestrant, continuing their same CDKI. The primary endpoint of this trial is one that I have a problem with. The primary endpoint here was progression-free survival from the time of randomization. So that was prolonged in those patients who switched to camizestrant from about 9.2 months in patients who continued the aromatase inhibitor to about 16 months in those patients who switched to camizestrant. Now here's the problem. They screened a little over 3,500 patients, ultimately randomized just over 300 patients. But my bigger concern is I don't think the primary endpoint should be progression-free survival from randomization. I think the primary endpoint should be progression-free survival from randomization for those who switched early and from randomization plus switching to camizestrant at the time of radiographic disease progression for those who weren't randomized to continue their AI. We don't have that data, and at least in the data that I've been able to see thus far, we don't know how many of those patients proceeded to either fulvestrant or elacestrant or any other hormone therapy if they continued their AI. We also have to consider that those patients who were found to have ESR1 mutations didn't progress rapidly. Median progression-free survival was 9.2 months. So this does give you significant lead time, but it's simply not clear from the design of this study if switching early ultimately provides benefit for patients. So the results are not surprising, but I don't find them compelling that we should be doing this, particularly when the likelihood of identifying patients if you start screening all of your patients was only about 10%. Now, let's shift our thinking in our last few minutes to those patients with triple-negative disease. And here we also have really exciting results from a trial that I think deserves kudos in a couple of different ways. This is the ASCENT-4 trial, looking at patients with triple-negative disease, not having received previous therapy for metastasis, and focusing on those with CPS scores of 10 or higher, so immune therapy would be appropriate. They were randomized to the control arm, a physician's choice of chemotherapy, either paclitaxel or the combination of gemcitabine and carboplatin, both with pembrolizumab, or the investigational arm of the antibody-drug conjugate sacituzumab with pembrolizumab. Now, this is also a positive trial with a significant improvement in progression-free survival, about a 5 to 6 month improvement in progression-free survival with the antibody-drug conjugate and pembrolizumab compared to reasonable standard of care chemotherapy pembrolizumab combinations. What I really appreciate about the ASCENT-4 trial is the organizers made sacituzumab available to patients in the control arm at the time of progression. Now, overall survival data for ASCENT-4 is woefully premature. They're only at about 20% overall survival information. That will require us to be patient and to continue to follow patients for a longer period of time. But I am particularly excited to see sponsors recognizing that the way to really thank patients for participating in these trials is to provide the ability to receive the investigational agent if they and their doctors think that's appropriate and an option they'd like to pursue. With progression-free survival being the primary endpoint here, they could provide that care without hampering the primary endpoint. And I personally find that benefit in progression-free survival to not only be statistically significant, but really of a magnitude that I think is important for our patients. We always have to think about toxicity. These are known quantities here. There were no new or unique toxicities, nothing in the toxicity data that is not exactly what you would expect from what we know of these agents. There will be many more things to come from ASCO. These are some of my highlights this year, and I think they portend really bright days for our patients with breast cancer. Thank you again for joining me. This has been Dr. Kathy Miller coming to you from the 2025 ASCO meeting in Chicago.